In this video, we're going to walk through the main fertility tests offered on the NHS, what they're looking for, how period problems like endometriosis or fibroids fit in, and the red flags you should never ignore. Welcome to Balanced Woman UK, where we provide evidence-based women's health information you can trust. Everything in this video is based on official NHS, Royal College of Obstetricians and Gynecologists, and NICE guidance, and I've linked all sources in the description below. Medically, infertility is when you have not conceived despite regular unprotected sex for a year. The NHS defines regular as sex every 2 to 3 days. The reassuring part is that more than 8 in 10 couples, where the woman is under 40, will conceive naturally within a year of trying. Around 1 in 7 couples will find it harder, and that's where fertility tests and support come in. You should see your GP if you have not conceived after 12 months of trying. You should see a GP sooner if you are 36 or over, if your periods are very irregular, extremely painful, or have suddenly changed, if you have had pelvic inflammatory disease, chlamydia, or significant pelvic surgery, if you already know you have endometriosis, adenomyosis, fibroids, or another gynec condition, if your partner has a known problem with his testicles or sperm, or you're single and planning pregnancy and want an earlier fertility discussion. You do not have to wait to suffer just to qualify for help. If something feels off, that matters. At GP level, before you are referred to a fertility clinic, your doctor will usually start with a careful conversation and some basic checks. They will ask about your medical and sexual history, including how long you have been trying, how often you have sex, any previous pregnancies or miscarriages, and whether you have ever had a sexually transmitted infection, pelvic infection, or cancer treatment. They will ask about your periods, whether they are regular, very heavy, extremely painful, or if there is any bleeding between periods or after sex. They will also go through medicines and lifestyle, including smoking, alcohol, recreational drugs, weight, exercise, and stress. A physical examination is common. For women, that may include checking weight and BMI, and a pelvic examination to look for tenderness, an enlarged womb, fibroids, or signs of pelvic inflammatory disease. For men, it may include checking the testicles and penis for lumps, swelling, or differences in size. From there, your GP will usually arrange fertility tests for both partners at the same time and refer you on to an NHS fertility or gynecology clinic if needed. The main fertility tests for women are designed to answer 3 simple questions. Are you ovulating? Is the womb healthy? And are the fallopian tubes open? Blood tests are usually the first step. A progesterone blood test, taken about 7 days before your period is due, helps show whether you have ovulated that month. If your periods are very irregular, you may also have hormone tests such as FSH and LH, which look at how your ovaries are being stimulated, and sometimes prolactin or thyroid function if there are clues that these might be affecting your cycle. You will usually be offered a test for chlamydia or other STIs using a vaginal swab or urine test because untreated infection can damage the fallopian tubes and cause infertility. If a test is positive, antibiotics are offered, and your partner should be checked and treated as well. Most women having fertility tests will also have a pelvic ultrasound scan, often done transvaginally with a narrow probe placed gently in the vagina. This scan can show the shape and size of the womb, the lining of the womb, and the ovaries, including any fibroids, ovarian cysts, or a polycystic appearance. It can sometimes suggest endometriosis cysts on the ovary or a bulky, tender womb that might be consistent with adenomyosis. To look at the fallopian tubes more closely, the NHS often uses procedures like HyCoSy, where contrast fluid is passed through your cervix into the womb, while an ultrasound checks whether it flows along the tubes, or an HSG, where a dye is injected and X-rays are taken to outline the tubes. Both can cause some cramping, but are usually quick, and you go home the same day. If there is strong suspicion of endometriosis, scarring, or blocked tubes, you may be offered laparoscopy, which is keyhole surgery through a small cut near the belly button. A thin camera allows doctors to see the womb, tubes, and ovaries directly, and they often inject dye through the cervix to check if the tubes are open. The advantage is that they can sometimes treat endometriosis or scar tissue at the same time as making the diagnosis. Fertility is never just a woman's issue. Male factors are involved in around a third of fertility problems. The main test for men is semen analysis. This looks at the number of sperm, how well they move, and their shape. If the first test is abnormal, another sample may be requested a few weeks later to confirm the pattern. Men are also usually offered chlamydia or STI testing, often a urine test, because infection can affect sperm and cause scarring. If sperm results are significantly abnormal, further tests such as hormone blood tests or an ultrasound scan of the testicles may be arranged, and a referral to a specialist may follow. Now, let's connect this back to painful periods and conditions you may already recognize: dysmenorrhea, endometriosis, adenomyosis, fibroids, pelvic inflammatory disease, and coil-related cramps. Primary dysmenorrhea is the medical term for usual period pain where there is no underlying disease. Pain typically comes with your period, feels crampy in the lower tummy, back or thighs, and is caused by natural chemicals called prostaglandins that make the womb tighten. If it responds well to anti-inflammatory painkillers like ibuprofen or naproxen and does not stop you living your life, it usually does not affect fertility. Secondary dysmenorrhea means painful periods caused by another condition. Endometriosis, where tissue similar to the womb lining grows in other areas such as the ovaries or pelvis, can cause severe period pain, pain with sex, pain opening bowels or passing urine, fatigue, and difficulty getting pregnant. It is diagnosed based on symptoms, imaging like ultrasound or MRI, and sometimes laparoscopy, which is the only way to confirm it definitively. Adenomyosis happens when the lining tissue grows into the muscular wall of the womb. It often causes very heavy, painful periods and a bulky, tender womb on examination. It can be suspected on ultrasound or MRI and may be linked with fertility problems and miscarriage in some women. Fibroids are non-cancerous growths in or around the womb. They can cause heavy or painful periods, pelvic pressure, pain during sex, and difficulty getting pregnant, especially if they distort the cavity of the womb or block the fallopian tubes. They are seen clearly on ultrasound, and certain types can be removed surgically to improve chances of conception. Pelvic inflammatory disease is a pelvic infection, often from untreated STIs, which can scar and block the tubes, increasing the risk of infertility and ectopic pregnancy. Symptoms can include pelvic pain, fever, abnormal discharge or pain during sex. IUD-related cramps are also important. More painful periods are common in the first 3 to 6 months after a copper coil is fitted, whereas hormonal coils usually make periods lighter and less painful over time. However, sudden new severe pain, foul-smelling discharge, or feeling very unwell after a coil fitting is not normal and needs urgent assessment. None of the self-care options can unblock tubes or cure endometriosis, but they can help you cope while investigations are underway. For period pain, anti-inflammatory drugs such as ibuprofen or naproxen can be very effective if they are safe for you. They work best when started at the first sign of pain or bleeding and taken with food. If they are not suitable because of asthma, kidney problems, stomach ulcers, or other medicines, paracetamol is an alternative. Heat therapy can be surprisingly powerful. A hot water bottle or heat pad on your lower tummy or back can ease cramps. Gentle movement, such as walking, stretching, or yoga, can also help for some people. Stress and poor sleep do not cause period pain, but long-term high stress levels can make pain feel worse and may affect general health and fertility, so focusing on rest and relaxation is still worthwhile. For fertility more generally, there are a few evidence-based lifestyle steps that support your body and align with NHS advice. If you smoke, stopping is one of the best things you can do for your fertility and your future pregnancy. Keeping alcohol within low-risk limits and, for many couples, choosing to avoid it while trying to conceive also helps. A healthy weight matters at both ends of the scale. Being very underweight or having a BMI over 30 can reduce fertility and affect periods. So working towards a balanced weight can improve outcomes. Using condoms with new partners until both of you have had STI checks protects your fertility by reducing the risk of infections that can damage the reproductive organs. You are probably already carrying a lot. The monthly disappointment, the pain, the rushed appointments, maybe a sense that you are not being fully heard. There is a clear next step you can take. Start by tracking your cycles and symptoms for at least 2 to 3 months, noting when your period starts and ends, how heavy it is, what kind of pain you get, and when you have sex. Then, if you meet any of the time-trying criteria or red flags we have talked about, book a GP appointment and bring your notes with you. In that appointment, it is completely reasonable to ask directly about tests. You might say, "Can we arrange fertility tests for both of us?" Or, "Will I have a progesterone test, ultrasound and tube check?" You can also ask, "Do you think endometriosis, adenomyosis, fibroids or pelvic inflammatory disease could be part of this?" If you feel nervous, you can take your partner or a trusted friend to support you. You do not have to do this on your own. Most importantly, your worth is not defined by how quickly you conceive or how stoically you cope with pain. Wanting answers and asking for them is reasonable, not demanding. You deserve clear information and compassionate care on this journey. Watch this video next to fully grasp the concept of infertility and how to handle it in line with the NHS guidelines.